development of drugs for GIST really happened in a very sequential fashion. So first we had imatinib, then we had Sutent, then we had regorafenib, and much more recently we've had avapritinib and ripretinib. So we oftentimes just sort of think of them in a sequential fashion because that's how they were approved. But there are some times when second-line therapy, you might want to use Sutent rather than regorafenib or vice versa. And some of that has to do with information about mutations. We know that for the majority of patients who progress on imatinib, particularly those with exon 11 mutations, and they're the ones who, that mutation or that group of mutations is the most common, and so the greatest number of patients are in that scenario. These patients, if you look at the disease that's progressing, they will still have that primary exon 11 mutation, but they oftentimes have additional, or usually will have additional mutations. And oftentimes they are additional KIT mutations. They tend to be grouped in two areas, exon 13 and 14, and 17, 18. And these two different locations are different parts of the kinases. And interestingly enough, the drugs work better for different types of mutations. So for the patients who have the exon 13, 14 mutations, Sutent is an excellent drug. It tends to control this class of disease, less so for the exon 17, 18. Regorafenib does some of the exon 17, 18, but not all of them, and so that's probably a better drug. So I think one of the challenges, however, in making decisions with this type of molecular testing is that oftentimes if we're taking a biopsy of the tumor, most people have more than one site of metastatic disease. And also, we know from patients who've had metastatic lesions removed that if you sample different parts of one tumor nodule, you may find different mutations. So one biopsy may give you one answer about what one mutation is, but that's probably not the whole story. Using blood to look at mutations based on circulating tumor DNA may give us a better sense of the whole array of mutations. This is, I think, evolving in terms of the testing, really understanding what the testing tells us. Certainly if the mutation is there, it reflects some disease burden that is present. And we know from studies that have incorporated this that oftentimes we can see a decrease in specific types of mutations within the blood. But I think as a standard of care practice, it's something that is evolving and I think still not part of the daily routine of how we take care of these patients. We have much more based our decision-making on CT scans or MRI scans. I didn't talk about PET scans, which can be helpful when you're looking at a patient who you think may be progressing, but you're not sure, is this maybe a tumor nodule that may have had some bleeding into it? Is this a tumor that really is having a therapeutic response, but for whatever reason the nodule has increased somewhat in size? Using a PET scan may be helpful because it tells you about changes in metabolic response. The other criteria or radiographic criteria that people have used is something called the Choi criteria, which looks at Hounsfield's units or the density of tumor lesions in a contrast enhanced scan, CT scan. And if the density of a lesion is decreasing, that typically is consistent with benefit, unless the tumor size is increasing significantly. So there can be sometimes, if you're not quite sure about whether a patient is responding, a PET scan can be a helpful adjunct to diagnosing or understanding what the scan is trying to tell you.